Morning, everyone. The moderator for my today's journal club is Dr. Mohan Jani, sir, and the topic is the use of antidepressants is linked to bone loss, systematic review and meta-analysis. Principal author is Michelle Mercurio, who's an associate professor in the Department of Orthopedic and Trauma Surgery, University of Italy. Publication is in the journal Orthopedic Reviews. The article was published online on October 13, 2022, and the authors declared that no funding was received to perform the study and there was no conflict of interest. So, Orthopedic Reviews is an international open access peer reviewed journal that publishes original research on all aspects of orthopedics and spine. Articles include diagnosis and treatment, trauma, surgical procedures, arthroscopy, sports medicine, rehabilitation, pediatric and geriatric orthopedics. Editor-in-chief is Patrick Massey. Impact factor is 1.96. So before we proceed towards the article, what is meta-analysis? Meta-analysis is an analysis of analysis. It is a technique for combining the results from different studies on the same topic for resolving discrepancies in clinical research. It is an objective, quantitative synthesis of research findings that increase the statistical strength and precision for estimating effects by combining the results of previous studies and thus overcoming the problem of small sample sizes and adequate statistical strength. When conducted properly, it occupies a top level in the hierarchy of evidence. So, what are the steps to perform meta-analysis? First, we have to identify a relevant research base, which can be PubMed, Embase, and Central. We have to check between study heterogeneity, for which we can use Cochrane Q test and I-square test. Then we perform meta-analysis using fixed or random effect model, and we can plot a Fordyce plot. Then we have to evaluate the sources of heterogeneity by performing subgroup analysis, sensitivity test, or meta-regression, which are extension of meta-analysis. Then we have to check for publication bias, for which we can plot a funnel plot, Egger's regression test, or trim and fill method. And we have to present meta-analysis result based on preferred reporting items for systematic reviews and meta-analysis. So about the article, osteoporosis is a systematic skeletal disease characterized by low bone mass and microarchitectural disarray of bone tissue with the consequent increase in bone fragility and susceptibility to fracture. According to the diagnostic criteria of WHO, osteoporosis is defined as a bone mineral density BMD score of minus 2.5 or less, and osteopenia as a BMD score between minus 1 and minus 2.5 BM. Depression and antidepressant drugs have been shown to be among the risk factors for osteoporosis, being associated with both low BMD and increased fracture risk. Selective serotonin reuptake inhibitors are the most utilized group of antidepressants, constituting more than 60% of all antidepressants prescribed worldwide. Interestingly, serotonin receptors and the serotonin transporter have been reported in bone, begging the question whether medications that antagonize serotonin reuptake would influence bone metabolism and consequently promote drug-induced osteoporosis. So, what is the need for study? Currently, there are inconsistencies in the literature regarding bone consequences of antidepressant drugs and the role of age and a natural decline of bone health in patients with depression. Since SSRIs may be associated with increased fracture risk, bone health should be considered when prescribing this class of drugs. So objectives were to investigate the relationship between antidepressant drug categories, including SSRIs, SNRIs, and TCAs, and bone mineral density. So they included studies using any antidepressant treatment for any psychiatric condition diagnosed according to DSM-4, DSM-4-TR, DSM-5, ICD-10, and ICD-11 criteria, or validated scales with cutoff, or clinical records where the bone metabolism, osteoporosis, and risk factors for fractures has been assessed or evaluated. Then the patients could be under chronic antidepressant treatment or be diagnosed with an early phase of disease and could be drug naive. All experimental and observational study designs, apart from case reports series, including retrospective, cross-sectional, or prospective designs were included. So patients who exhibited general medical, neurological comorbidity or unclear or unverified diagnosis according to ICD were excluded. Narrative and systematic reviews, meta-analysis, umbrella reviews, commentaries, opinion pieces, expert opinions, editorials, related to editor and book chapters were excluded. So, material and methods. This systematic review was conducted according to the methods recommended by the Cochrane collaboration and documented the process and results in accordance with the current most updated preferred reporting items for systematic reviews and meta-analysis, PRISMA guidelines, searching on PubMed, Medline, Cochrane database, and Scopus library. So, quality assessment. The authors independently assess the quality of selected studies using the modified version of the Newcastle-Ottawa scale for cross-sectional studies, and disagreements by reviewers were resolved by consensus or involvement of a third author. This was the quality assessment. All studies showed high quality. Now, statistical analysis was performed with JASP open software, which conducted a publication bias and adjusted meta-analysis applying a robust Bayesian meta-analysis method, which is the ROBMA method. So what is a publication bias? Studies showing positive effects tend to be published more frequently than those showing no significant results. As a meta-analysis includes only published studies, it might overestimate the actual effect degree. This outcome is called publication bias. So ROBMA with competing publication bias adjustment methods were used given the potential heterogeneity related to patient populations, interventions, comparators, and the inherently large variability of the outcome variables. So records were identified through searching database of Medline, Scopus, and Cochrane. Additional records are also identified. So total record which was claimed was 3076. Then studies were excluded based on title or abstract. Then full text articles were assessed, which were 104. Then further the articles were excluded, which had no antidepressant use, no BMD was assessed. And the final articles in systematic review were routine, and in the meta-analysis were totally 5. So characteristics of included studies and participants. The studies were carried out all over the world, which were published between 2005 and 2020. Briefly, the 18 studies, including the analysis, contained data from 4 to 656 participants affected by different subtypes of depression. Among the included studies, 10 used only SSRIs, 6 involved use of SSRIs and TCAs, and 2 the combined use of more than 2 antidepressants. The studies enrolled patients of all ages, ranging from teenagers under 18 years of age, young adults between 18 to 35 years of age, to adults 36 to 64 years of age, and elderly over 65. The follow-up period reported in the included studies ranges from a minimum of 3 months to a maximum of 204 months. Among the included studies, 7 reported a statistically significant difference in BMD reduction between the antidepressant exposed group and the control group. 2 papers found a clear tendency for BMD levels to decrease in the group of patients exposed to antidepressants, but without reaching statistical significance. So these were the 7 studies which showed significance. Ma'am, शुरू में 3076 study से क्या था? Finally meta-analysis में 5 studies दी थी. ये जो आप बोल रहे हैं studies में out of how many studies? Ma'am, 7 were significant. As in out of 3076. The outcome measures. Primary outcome was the evaluation of BMD, bone metabolism, and bone health in general associated to concomitant antidepressant use. Secondary outcome was the fracture risk related to the use of any antidepressants for any psychiatric condition. So results were plotted on a forest plot. All 5 studies had a significant single effect size, the minimum estimated effect of 0.15 and a maximum estimated effect of 0.46. Overall, a significant effect of SSRI on decrease of BMD with a mean effect of 0.28%. So the systematic review with meta-analysis for the first time provides evidences about the correlation between all antidepressant type use and BMD, greatly reinforcing the idea of a biological implication of antidepressants in bone tone. The search identified results mainly for SSRIs, with a little portion for SNRIs and TCAs, finding no significant studies meeting the inclusion criteria for most recent categories of antidepressants, such as vortioxetine and esketamine. This could be due to a shorter availability time to study more recently accessible drugs. Moreover, it could be linked to the different mechanism of action without a direct influence on bone metabolism. In this regard, a large case control study conducted in Denmark on fracture cases and age and gender match controls examined exposure to various antidepressants of all categories and a number of confounders on the risk of fractures, finding an increased risk only for SSRIs and TCAs, but not for vortioxetine, mirtazapine, reboxetine, or others. A large and recent cohort study conducted by Copeland and colleagues demonstrated how all classes of antidepressant drugs were associated with significantly increased risk of all-cause mortality, attempted suicide or self-harm, falls, fractures, and upper GI bleeding. In particular, the fracture risk was higher with SSRIs, TCAs, or other antidepressants by 1.58, 1.26, and 1.64 times respectively compared to no users. However, it is interesting to note that the use of antidepressant increased the risk of fracture, and this could be interpreted as possible long-term clinical result of the drug's action on BMD. This is comparable with results where the observed decrease of BMD in SSRI users group is likely to contribute to an altered bone turnover with a mismatch between bone formation and resorption, resulting in overall bone loss. So, strengths of the study. This is the first systematic review and meta-analysis evaluating the correlation between our antidepressant drug categories and BMD. The study clearly mentioned the exclusion and inclusion criteria in accordance with standard diagnostic systems. A publication bias was conducted and meta-analysis was adjusted using Rogma method, which took into account the heterogeneity of the data and inherently large variability of outcome variables, thus eliminating potential confounders. They use more than 3 databases, which is necessary for the strength of meta-analysis. So limitations. The great heterogeneity of the data in selected studies prevented conducting a comprehensive quantitative analysis between them, thus reducing the final number of studies and therefore of patients comparable to each other. Age, gender, duration of drug intake, and particular risk factors were not taken into consideration. The small number of studies included and the paucity of data found in the literature led to indefinitive conclusions, which therefore remain only plausible and should be confirmed by further prospective studies designed specifically for this purpose. Only SSRIs were extensively included in the studies without significant data on other classes of antidepressants. Critical appraisal. The journal is an open access that is available to all in a peer-reviewed journal. The article takes publication fee from the author, which is a barrier to publishing. The study design is clearly mentioned and it clearly defines the topic they want to study, but not the study population. The topic, depression and antidepressant drugs have been shown to be among the risk factor for osteoporosis, being associated with both low BMD and increased fracture risk. Serotonin receptors and the serotonin transporter have been reported in bone, which could influence bone metabolism and consequently promote drug-induced osteoporosis. Methodology, the study design is clearly mentioned. Strict inclusion and exclusion criteria were mentioned, which is important for the strength of a meta-analysis. The result was presented in a logical and comprehensive manner. All results have been presented in tables. Charts could also have been used, and data given in text and table match with each other. So, and the discussion in the article is meaningful and tells the important findings of the study. Basically, SSRI and TCS. Good last time SSRIs and TCS are called bulls. मैंने मेंशन नहीं किया था उन्होंने बस ब्रॉडली हाँ मैम SSRIs over TCS स्पेसिफिक नहीं है SSRI बता मैम डेक्सा स्कैन होता है बहुत कॉस्टली है स्कैन एक स्कैन कॉस्ट आता है अराउंड 10,000 पड़ता है तो इसके लिए क्या करना है पेशेंट को सप्लीमेंटल कैल्शियम कितने लेना है मतलब बीएमडी बढ़ा देके क्या करते हैं कैल्शियम या जो मेडिसिन आती है तो स्पेसिफिकली बीएमडी बढ़ा ओनली कैल्शियम विटामिन डी पेशेंट के रिलेटेड साथ को डिस्कस करना है कैल्शियम मतलब इसमें वी कैन अवॉइड SSRIs in older age individuals with the class of antidepressants. This one more thing, they की स्टडीज में उन्होंने SSRI देने से पहले बोन स्कैन किया था मतलब मेटा एनालिसिस इन्होंने किया ना तो जिन सब स्टडी का इन्होंने कहीं मेंशन किया है कि हमारी इंडिविजुअल स्टडीज हुई थी हाँ तो उन्होंने कहीं इसे मेंशन नहीं किया कि उन्होंने पहले किया था नहीं बाद में किया उसको अभी पता चलेगा ना कि अभी हाँ मैम जो और स्टडी मेटा एनालिसिस है तो मैम पहली स्टडी में हुआ है ये और ये भी क्लियरली इस एज ग्रुप में हुआ हाँ मैम ये भी लिमिटेशन है स्टडी का सारे एज ग्रुप्स में सब में हुआ था वहाँ पर ये एज लिया नहीं अच्छे से तो लिमिटेशन है स्टडी की हमारे हॉस्पिटल होता है स्कैन अगर आप तो चलो डेजिग्नेशन मिल गया बच्चे हमारे होता है हॉस्पिटल में स्कैन गोल पर पूछते हैं ऐसे कैंप्स लगते हैं डिक्सा स्कैन पे कुछ कंपनीज होती है वो जिनके पास स्कैनर होते हैं तो वो कैंप्स लगा लेती है बीएमडी से स्क्रीनिंग के लिए वो बोन मैरो डेंसिटी असेस करते हैं सीरम टेंशन नहीं मैम बोन मैरो डेंसिटी असेस करने के लिए मैम वो बड़ी सी मशीन होती है उसकी तारीफ करते हैं तो वो बोलते हैं
हाँ यहाँ पे। अच्छा मैंने करा था वो मशीन में आपको
पैर रखना होता
पैर रखना होता है ना।
हाँ।
हाँ मैंने भी करा हुआ
अच्छा।
है। तो उसके लिए 10,000 रुपये लगते हैं।
कॉस्टली है।
मशीन कौन सी? Anyways, कौन सी जो आप ऑर्थोपेडिक्स